Today we are going to talk about primary amenorrhea. First, I'll give you in 10 minutes brief points on which you should focus while taking history of a patient. First is age. We know that menarche generally is between 10 to 12 years these days. So if a young girl doesn't get her first menses, which is known as menarche, it's pronounced as menarche. Generally you people call menarche. No, menarche. Generally, if the young girl doesn't get her menarche by 12, mother gets worried. So she comes to you, and by that time, general puberty signs are minimal. So you can do general examination. If breasts are developing, pubic hair and axillary hair are developing, you can reassure that perhaps her menarche is delayed. The best investigation, non-invasive, you should perform is ultrasound, which will show infantile uterus, small uterus and ovaries. It's okay. So you reassure that perhaps it's delayed menarche, and ask her to come back after maybe by the age of 14. Mother comes back to you, still no menarche. Then you ask one question: does she get abdominal pain, lower abdominal pain, cyclically every month? So one question added. Number two, is her height and weight according to the age? Number three, what is the status of secondary sex characters that is described in terms of Tanner 1, 2, 3, 4, 5. These are all history and physical examination. Investigation would be only ultrasound up to the age of 14. Unless in the first part where I said her height, weight, secondary sex characters, these three things put together, they indicate that child, I would call her child, young girl, her growth is not normal, height is short, she is underweight, or there are symptoms of, say, like hypothyroid or any infection like tuberculosis. If there are none of those, in addition to, by age of 14, I'll do ultrasound and blood tests, especially top of the list, thyroid. Number two, gonadotropins, FSH, LH, prolactin. And number three, estrogen, 4, whatever. That means ovaries produce estradiol, estrogens. And ultrasound. If there is pain and cyclical pain, then inspection of the vulva for imperforate hymen bullish membrane. If all this does not help you to reach a diagnosis, they are all normal. All normal. Maybe you can stretch the diagnosis delayed menarche up to 16. Reassure, ask her to come back. But if she insists, generally mother insists on further investigations, even at 14 they are valid. Otherwise, by postponing at 16, you should do the regular investigations. Now, before we go on to investigation bit, let's make a list of possibilities. Only then you will know what investigations are to be done. Now, here is a patient who is now, the diagnosis changes from delayed menarche into primary amenorrhea. So we are making a list of causes of primary amenorrhea. I don't have to revise with you physiology of menstruation. Physiology of menstruation. But generally, if we just pick up the headings of physiology, menstruation is related to higher centers, then pituitary, then ovaries, and then uterus. This is the cycle related to genital tract, to uterus. But all these are also influenced, all these higher centers, pituitary, ovary, uterus, they are also influenced by other factors in the body. First, hormonal, thyroid, adrenal cortex. Next, in endocrinal, you can put even pancreas, insulin. After hormonal factors influencing this cycle, which we have already put in, after that, next is any infection. In Pakistan, tuberculosis. Then drugs, iatrogenic, psychotropic drugs, hypotensive drugs, psychotropic tranquilizers, then chemotherapeutic drugs, oncology. Then, last of all, stress, overweight, underweight. And draw a line under the list. Don't forget pregnancy, pregnancy, pregnancy. Even in unmarried girl. If you remember this last, but most important, it will save you embarrassment. Maybe it has happened to me. It has happened to me. One of my registrars came, and that her younger sister, 12-year-old, menarche is not there, but she has got ovarian cyst. This is before ultrasound times, way back 50 years ago. I examined her, there was a big mass. 12-year-old. I said, oh yes, it's a big ovarian cyst. Did laparotomy, next day it was gravid uterus. The girl was pregnant before her menarche.
So fetal part नहीं है पहले वो हुआ है. Fetal parts से पहले नहीं हुए. PA के ऊपर fetal parts.
क्या?
Sir fetal parts नहीं आपको feel हुए.
You know, this is very important. What mind doesn't know, eyes don't see. What pregnancy was not in my mind. And as it wasn't in my mind, eyes don't see. So if I had kept that last differential diagnosis in my mind, it would have saved me embarrassment. Not only my embarrassment, it embarrassed that registrar, embarrassed that little girl, everybody. So remember this, primary amenorrhea, I have drawn a line, list is complete. But under that, always keep this thing. These days, because you always have ultrasound, so you don't have to worry too much about it, but still it should be in your differential diagnosis list. And there's one test which is people are very fond of, but I rarely do that. That is genetic anomalies. Other than this list, Turner syndrome and you name it, all that. And it's of course possibility, but I keep it even after pregnancy because this is the first tip of the day. You should order those investigations which are going to help the patient. Making a diagnosis which is no help to the patient is of academic interest. You make us spend a lot of money on that test to find out various trisomies and other abnormalities. I don't. But obviously that list remains, as a matter in the books, it's high up on the list. It is high up on the list. So if this is the list of differential diagnosis, now one by one we can easily cover that. Starting from higher centers. If there is some anomaly at a higher level, like that, what's the name of that diagnosis in which the patient loses smell? Oh, mashallah, mashallah. Very good. What's the name of your husband? You remember? Don't? Never mind. So, from there, then we come to pituitary. And pituitary, we know, hyperplasia or adenoma, microadenoma, macroadenoma. But before we go on to that pathology, that first thing which we put is physiology. If pituitary doesn't function, then FSH, LH will tell you. Or if it does function, but ovary doesn't respond, then because there is an inhibitory feedback relationship of ovarian function with the pituitary, if ovary doesn't function, FSH will be high. Arbitrarily, it has been decided if FSH is more than 40, then we call it hypergonadotrophic amenorrhea. And if there's something wrong with pituitary, doesn't produce FSH, then FSH will be very low. That is called hypogonadotrophic amenorrhea. Then we come to the ovaries. Ovarian function can be easily assessed, number one, by ultrasound, its presence, size, and presence of estrogens and progesterone. We come to the uterus. Presence or absence of the uterus will show. This can be found out by ultrasound. If it is present and still amenorrhea, then it could be refractory endometrium. That endometrium does not respond to the stimuli of the hormones. Or endometrium was normal, but it has been destroyed either by infection or by adhesions, Asherman. And below uterus, everything is normal, but blood doesn't come out, cryptomenorrhea, imperforate hymen. We have completed this cycle, physiological cycle. After this, we come to others. I will not go through the list of investigations of thyroid, adrenal cortex, pancreas, infections, and all that. If you suspect those, do the relevant investigation. Only this. Now, just a brief note, although I don't order those tests. If at all you suspect chromosomal anomalies, then karyotyping can be ordered. I don't, because it costs thousands of rupees and does not help in management of the patient. What helps you in management of the patient? Anatomical anomalies or hormonal production, which anatomical anomalies you can diagnose through ultrasound, or hormonal production you can make a diagnosis through the lab. Now, after you have done these investigations, draw a line. Clinical management of the patient. I have used the word clinical management of the patient with primary amenorrhea. Most important thing is, in our country, one, whether you can help your patient to menstruate, to develop secondary sex characters, 3, whether she'll be able to get married and produce children. These are the questions which mother will ask you. These are the questions. If her secondary sex characters are not well developed, whether we can help them to develop, then whether we can help her to menstruate, and third, what happens if she gets married? Will she be able to have coitus or produce children? Will she be fertile or not? So, after taking history, physical examination, and the relevant investigation, prepare yourself to answer those. To answer those. I have used the word clinical management. And clinical management is that you should be able to answer these queries and also, wherever possible, provide relief or treat. Today we remain focused on pituitary, ovary, uterus, vagina. Because if you make a diagnosis of thyroid deficiency, diabetes, tuberculosis, any of those other than out of the cycle, you will treat that. If she has got hypothyroid, you will treat that. If she has hyper, you will treat that. Similarly, all those, we will not focus on those. We will focus on this. For clinical management, first thing is to find out whether the uterus is present or not. So many cases, developmentally, either uterus is absent or it is infantile. Number 2, similarly, whether ovaries are present or they are also infantile, very small, they have not developed. The other end is ovaries are present, but their function is abnormal. In this category, PCO also comes in. And next, above uterus, ovaries is pituitary, gonadotropins, FSH levels. If it is hypertrophic, it means ovaries are not functioning. If FSH is beyond 40, it means like menopause. Ovaries are not responding. So ovarian failure, whether developmental or subsequently premature ovarian failure. In such situations, the diagnosis is that in reverse order. I said first secondary sex characters, then menstruation, then marriage, coitus, and reverse order. She is a patient where we can help her to have secondary sex characters. We can help her to menstruate. Help. That means we will do something, we'll give her something. So we can help her to menstruate. If vagina is present, she can have coitus but no children, no fertility. This is my view. You may agree, you may not agree. I give this information the moment diagnosis is made. Whether the child is 14-year-old, 16-year-old, 18-year-old. My argument about telling very frankly, I would say bluntly, this diagnosis is, I always tell them, it's generally the mother who is talking to the doctor, that your daughter, you can marry her off because she has got vagina. If she doesn't have, we can create vagina by Williams vaginoplasty or some other method. She will be able to have coitus, but no children. I add on that educate her well. All that money which you are going to give in dowry, spend on her education, make her a doctor. Doctors are in great demand. In great demand. I mean, obviously, 50% of the lady doctors in Pakistan, they are housewives. They don't work because they get married into the good family. They don't need money, so they don't work. But for a lady doctor, no questions are asked. Mother-in-law doesn't pressurize children. My grandson, where is my grandson? Such embarrassing questions. So, educate her well and marry her off into a family where the husband already has children. This is my advice. This is my advice. Then, because if the husband doesn't have children, the mother of the husband is after the wife. My grandson. So, but if it's a lady doctor, there are already children. Lady doctor is a hen which lays golden egg. Where do you hide your eggs? So, this is kind of, if you cannot, ovaries are non-functioning for some reason. On the other hand, if ovaries are non-functioning, uterus is there, maybe we can give her cyclical hormones which will help uterus to grow in size and also endometrium to grow in size and menstruate. In the book, it's written a combination of estrogen, initially only estrogens, then combination of estrogen and progesterone. My clinical practice, I made it simple. I prescribe OCP, oral contraceptive pill, because it has minimal dose. So I ask them to take 2 or 3 pills at the same time every day to enhance the dose. I do this because OCP in Pakistan is only 4 rupees. So it's feasible for all families financially. Only 12 rupees for the month. Whether the parents are rich or poor, they can easily afford. So if uterus is present, ovaries are non-functioning, then treatment is like HRT, hormone replacement treatment, to help the uterus to enlarge and also bleed cyclically, which will be called menstruation. For this, a theoretical answer is first, estrogens. There are a lot of brand names of estrogen, Proguy, Nova, things like that, but they are expensive. Why not make it easy, comfortable, cheap? So I asked them to buy 2 or 3 packets simultaneously and take 1 pill out of each packet and take them. Because if they take from 1 packet 3 pills, that will disturb the cycle. It's important. If they take 3 from, then they'll reach brown very soon. It will shorten the cycle. But if they take 1 each from 3 packets, then the cycle of 21 days will remain. So anyway, treatment is giving her estrogens and progesterone. Very rarely the girl is XY chromosomes of male and has testes somewhere hidden, but there is androgen insensitivity. Generally in such cases, testes, they are present in the groins. After puberty or growth is achieved, it is recommended the testes should be removed and replacement treatment should be given, like I have told you. Because the risk of those gonads giving a malignancy is high. I summarize. Generally speaking, clinical management of the patient who has primary amenorrhea, first you identify whether the cause is in the higher centers, like anorexia nervosa, or in the pituitary. Then, after you have identified the cause, if it is FSH very high, hypergonadotrophy, it means failure of the ovaries. It means ovaries don't function, so you can't do anything. So it has to be replacement, as I've told you. And if ovaries are not functioning, uterus is there, we can give replacement therapy. Here it will not be called replacement, enhancement as a matter of fact. Enhancement therapy to bring cyclical bleeding and also growth of the uterus. I would imagine in such a patient, if the uterus is grown sufficiently, then fertility will be possible by donor egg. She can't produce eggs. So donor egg, fertilization and growth in her uterus, if uterus is of sufficiently large size. जी, आप you wanted to ask question?
Sir, from exam point of view, same pattern follow करते हैं जैसे suppose in exam long case में primary में
Whatever I have told you is exactly for the examination. Exactly for the examination. That a girl with 17, 18-year-old primary amenorrhea brought to you for the examination. You'll take history related to whatever the causes we have enumerated. Then do physical examination for secondary sex characters. Then ask for ultrasound report of the pelvis, uterus, ovaries, and if you feel a mass in lower abdomen, you will say, I'll inspect vulva for bluish membrane for cryptomenorrhea. Generally it won't be. Generally it won't be. After you finish, then you will say her secondary sex characters are tenor 3, 4, 5 and her breasts are, because of this size, they have to be developed further. So what can you do? And generally speaking, it will boil down to giving hormones. How and for how long? This treatment will last not months, over a longish period. But this is exactly what, keeping your examination in mind, this is the way I have described. It's not the way written in the chapter, not even in my book and in other books. I have made it very simple. That hypergonadotropic, hypogonadotropic, and clinically correlating them, and then chromosomal anomalies I've kind of excluded, because all of you know that. You read that and you try to put them first. I put them last, because those anomalies cannot be treated clinically. They can't be, except XY female, which I have told you, that has to be done like that.
So can we do PR, parental examination for the patient?
I suppose when I was at your stage, PR was essential. PR is very unpleasant examination. Very unpleasant examination. Patients, for men, for prostate, they don't mind. But for women, they don't mind per vaginum examination, but they do mind when you insert a finger into the anus. So I would say, my answer to this, your query would be, Madam, if ultrasound is conclusive, then I will not do PR. Use this word. To preempt examiner's question. Preempt. That I'll ask for ultrasound. If ultrasound report is satisfactory, then I will not do PR. But if it is not, or if the patient is married, TVS is definitely superior to PR. TVS, transvaginal sonography, is definitely superior to putting a finger into the anal canal. So if most 99% it will be a married girl in the examination hall. Unmarried girls, very few patients. So if she is married, you're asked to do PR, why don't you do PR, why didn't you do PR? You say, Madam, in this case I'll ask for TVS, which is much more and comfortable for the patient.
Sir, अगर girl unmarried हो सकती है, अगर unmarried हो girl,
लेट आने का यही नुकसान होता है. I have told that if it is unmarried girl, even for local inspection, you will seek permission. Seek permission, and definitely in the examination, particularly, you will say, because she is unmarried, I will not do PV or ask for TVS. It will be a transabdominal examination. But I don't know. It's beyond my conception. Why are we so sensitive about hymen? It must not be torn, it must be intact, things like that. Socially, this is the culture, Pakistani culture. Like genital mutation in Africa, this is their social culture. Even educated Africans who are posted as ambassadors, at that level, they bring their daughters to Africa for genital mutation. This is called genital circumcision. And they still indulge in spite of the fact that all the international organizations are after them. For God's sake, don't do it. For God's sake, don't do it. Even for male circumcision, people are against it, because the previous thought that it saves you from cancer of the penis and or cancer of the cervix is statistically it has not been proven. And secondly, in England, although everybody doesn't get circumcised, still every year 1 to 2 deaths take place because of bleeding due to circumcision. But we do it because religiously we believe in it.